What's up, everybody? This is Maggie Reichart, and you are listening to Nursing Uncharted, the podcast that delves into all different types of specialties within nursing. Thank you so much for listening today. If you have not checked out our Instagram, please check it out at Nursing Uncharted. If you have a specialty that you really want to listen to, or if you have somebody like, I've been listening to this person online and I would love it if they were on your podcast, shout me, give me a DM message at Nursing Uncharted on Instagram, and subscribe to our YouTube channel, Nursing Uncharted as well. We just hit 1,000 subscribers at the end of December, so we want to keep that going. So today, I'm super excited. Our current listeners know that I am postpartum. I had my daughter in November, and I had a midwifery team that I loved so much. And so I'm so excited for this episode today. It's talking about Certified Nurse Midwives. And I found a wonderful ambassador for this field to talk about CNMs, and that is Leslie Cornwell. So Leslie Cornwell has been a certified nurse midwife for the last 10 years. She's practiced in the hospital, in birth center, in the home setting, and in 6 different states. So she's a wonderful ambassador for this. She runs multiple businesses as well, including Midwifery Business Consultation and Empowering Midwifery Education. So she has an extensive knowledge when it comes to helping midwives start and improve their businesses and private practices. So she does a lot of consulting, but she also still practices. She does locum midwifery across the U.S. to keep her skills up. So Leslie, welcome to the show.
Thank you. It's always fun to be on the other side of this because I'm used to, with my podcast, interviewing people, and like I'm used to like talking and talking. I'm like, nope, I'm not going to interrupt her. I'm going to keep my mouth shut. It's a hard thing to do. But thank you for having me on. I was very excited. We were just talking before the recording how the universe, I was like, I need to find some new podcasts. There's only so many in midwifery, and you get overwhelmed with the searching. And then literally the next day you had reached out. So I was like, okay, the universe is listening. So thank you.
You absolutely manifested this. It's so funny. You're like, I'm so glad that I found you. I was going on, for like months, I wanted to have a certified nurse midwife on, even before I delivered. And so I was listening to your recent podcast. I think it's Empowering. Oh gosh, which one? Midwifery Wisdom podcast.
Yeah, that was with Augustine Colebrook. Yeah, she's a wonderful international midwife. She used to be U.S. based, but now she's in India, opening and running birth centers there. So, I've been around birth since age 16. I knew I always wanted to be a midwife, and I think it was as you get older, you realize the alignment is it was a massive woman empowerment. I always knew I'm like, this is a no-brainer. It's either be a wedding planner or catch babies. Like you need this like essential point in someone's life that's lifelong. It's pivotal. It has to be perfect. And the honor that a midwife gets. So I'm Michigan based, and when you're talking about February, it's like a heat wave here. It's like 40s and the snow's melting, which is super unusual.
Heat wave.
Yeah. I'm from Michigan. We just got midwifery regulations for community-based midwifery. When I was 16, I was like, I don't know if I really want to push the envelope of going to jail, practicing medicine without a license. I'm very type A, oldest child syndrome. So I chose nurse midwifery route because I can do the most. I could choose to be in the hospital. I could choose to be at a birth center home. If I chose certified professional midwife route, it's very heavy community based. It's only birth center and home at this time. So I don't know what I'm going to be like in 5 years, 10 years. So I always had the holistic mindset. I had my 3 babies at home. I ran a private home birth center practice, but being a nurse midwife, I could just do so much more. So I have a master's in nursing. I was very blessed to have a local hospital. I started as a nurse assistant in ortho neuro, and then immediately got to do labor and delivery as soon as I graduated, which I know is sometimes very hard to get into nowadays. I had a very I'm going to be a labor and delivery nurse. I got to have that prerequisite for most of the schools for nurse midwifery. It was a 2.5-year program of masters, and you can practice anywhere in the country, and it's just a very exciting pathway if you want to help out moms and babies.
Yeah, I was going to say, when people are looking at or just having the idea of wanting an advanced practice degree, I mean, we hit on them, just now, but like, what are some of like the really, pivotal, integral aspects of midwifery. That why would people want to choose midwifery over like being a nurse practitioner or a CNS or some of those other advanced practice options?
Well, each one has its own scope of services. So it really comes down to who do you want to serve? Like family nurse practitioners can serve anybody. They can serve babies, they can serve kids, they can serve guys, they can do anything, but they can't catch babies. So nurse midwives is the only certification that you can catch babies. Like women's health nurse practitioner is almost identical to our services on the clinic side, but they still can't catch babies. Out of all the advanced practice nursing roles, this is if you want to catch babies, you got to be a nurse midwife.
And midwifery though, but you can, like midwifery kind of encompasses the women's health, like nurse practitioner role, but so it's almost like, more broad 100%. In the scope of practice.
Yeah. People don't quite understand. We are primary care providers for women. So as soon as they have their first period to postmenopausal, we can do their hypertension, thyroid, diabetes. We are that family nurse practitioner that can catch babies. So I think a lot of people narrow down, well, I don't want to catch babies. I don't want to be in the birthing realm. I'm like, you could still be a certified nurse midwife and you can work in a clinic. You can work anywhere with women. You just can't take care of guys and kids past the first month of life. Like there's just a narrowed range of the scope. So it just depends on what you want to do, but don't ever hesitate. Because there's lots of wonderful nurse midwives that practice and don't catch babies, and they just become the primary care provider for women.
Yeah, I had no idea that was like when I think of nurse midwives, I think of just birth.
And that's a common thing. Like I have a private women's health clinic that I've done independent contract in my community. I help out like geriatric clinics where maybe it's an underserved population and they haven't had a PAP in forever. I've done some independent contract. We just say, well, here's your nurse, your advanced, here's your provider taking care of you. Because as soon as you'd say midwife, people are like, I'm 55. Am I confused? Am I pregnant? Did you catch something? It's a stigma, not just like in the community as a whole. It's part of our scope, but few people know what a midwife is, and even fewer know that they can do more than catching babies.
Yeah, absolutely. That makes total sense to me. When I was in prenatal, like taking prenatal, the prenatal period, and I was trying to figure out, do I want a midwife or do I want an OB team? What do you think is the difference when you're providing care, or like the philosophies behind nurse midwifery versus OBs?
Well, I can teach you kind of the core philosophies of school. Everybody's going to bring in their style, just like there's some physicians that practice like midwives, and then there's some midwives, we joke they're more midwives. You wouldn't be able to tell the difference between how an OB practices and some of the midwives out there. So it depends on your training, but the overall philosophy, there's the physiological birth philosophy, the midwife model of care, and then there's more the traditional medical model of care. So the big differences are midwives are taught birth is normal. This is a normal process. Your body knows how to grow your baby. Your body knows how to birth your baby. Your body knows how to feed your baby. But we have the knowledge and skills to support if something happens. If you all of a sudden have an emergency, we can completely handle those. We can completely collaborate and refer off what needs to be. Because a family practice physician doesn't know everything. They don't do C-sections. They can still catch babies. It's that same working relationship with the higher risk care providers. Obstetricians are trained in minimal normal and mostly high risk in surgery because that's the obstetrician's job. We're just a little confused in the United States of that hierarchy and that support compared to other countries. Many other countries, in like the Mayo Clinic has a great foundation to it. You see a nurse midwife, and then if you risk out of the nurse midwife, then you see an obstetrician. Like we have it backwards, that obstetricians do high risk and normal, and then few people know what a midwife is.
That is so true, because I think what I just wanted like a low intervention. Yeah. I feel like we, definitely in the US, we tend to over medicalize birth. And I felt like my only avenue of having a low intervention, or almost not guaranteeing, we never know what's going to happen. But, yes, starting with midwives, because that there is so much, I think there's room for both camps, obviously. And, OBs kind of are like, no stone is unturned. We're going to look at, everything. And I think that tends to sometimes lead to more interventions than maybe 100%. You would want to.
Oh, the data supports that time and time again. Intervention leads to intervention. There's very classic OB historical increments of when C-sections drastically increase, poor outcomes. The preterm labor, the infant maternal mortality is pretty much the worst in the world in the U.S. We pay about 8 times more for our health care for our moms and babies, but we are terrible at taking care of them because we do things backwards. Like, it is really about prevention and making them as healthy as possible, education, confidence, giving them a one-on-one support. That's why doulas are a huge initiative across the government platforms, that one-on-one support. When you're in the hospital setting, you have a nurse that has 3 other clients. The midwife and the doctor, even in the hospital setting, tends to come in when the baby's about ready to come out. We have these misunderstandings like, oh, I'm going to go to the hospital and a doctor's going to take care of me. You're getting the nurses covering the shift. With birth centers with private practice, I joke, you get the Cadillac of care for low-risk, healthy women.
Yeah.
It's not a setting. Like, I'm grateful we have C-sections. I'm grateful we have NICUs. I'm grateful we have all this extra equipment. But what's happening, normal, healthy women are starting to become routine high-risk management versus we should have a philosophy segregated. These women are normal and healthy. Intermittent monitoring of babies should be standard of care. What most of the time happens in the hospital setting is continuous monitoring.
Sure.
And that was implemented in the 1970s when epidurals were implemented in litigation in the 1990s. Those were those huge increments of interventions and poor outcomes. We aren't improving outcomes at this point. We've got to look at things differently.
Yeah, absolutely. Oh, there was so much good messaging in there.
Yeah.
I feel like it's just not knowledge to everybody that like this doesn't
it's
really.
It's not the cultural norm. I mean, that's the part, like I stress to people, it's a fear not because of a safety fear. It's a fear because not all your friends are doing this. You're going against the grain.
Yeah.
And so education and advocacy and learning the data. When you actually, like, the Lancet Journal for Midwifery has an amazing, I think it was 2016. If you read the data and the research on your own, it's not the norm. It's not. Midwives should be the front line for moms and babies, and then we use and we utilize and support with a team approach for if they need additional things.
Sure. Yeah. I know you were talking about doulas, and I can't plug doulas enough. You know, I had a doula, and it's because the expectation is, you know, that you'll have somebody with you to take care of you, and it's not all
the system's not. It's not the fault, and I stress it's not the doctor's fault. It's our medical system is not designed that way. Insurance reimbursement is set up as an assembly line. You do not want mental health and maternity care services set up as an assembly line, but that's the way the system is.
Yeah.
So that's why a lot of people, unfortunately, have to pay cash. They have to do out-of-network to get high-quality care because if you want to choose the Affordable Care Act, Medicaid, the insurance to cover things, you're going to be part of the major system of just grouping together versus individualized healthcare.
We'll be right back to our interview. Grab a cup of coffee, but don't go anywhere because we want to talk to you about our podcast partner, American Mobile. No matter your specialty, American Mobile has endless travel nursing opportunities. With the largest clinical team of all staffing agencies, American Mobile is ready to support you in achieving your career goals. To learn more about the benefits of American Mobile, like higher earning potential, premium health coverage, and 401k matching, make sure to visit AmericanMobile.com to speak with a recruiter. Again, visit AmericanMobile.com to discover your next travel nursing adventure. Now, back to the show. So does working in a birth center or home birth, is that technically like out of pocket expenses then?
Not necessarily.
Like, how does that work with?
It really has to do with how the business sets up. So think of it, if you saw a doctor, they can choose to be employed by the hospital or they can choose to have a private practice. So you have bills you get from the hospital and then you get bills from the doctor, the midwife, the care provider. So there's birth centers all over the country. There's federally qualified health centers. There's nonprofits. There are many birth centers that are in network, and it would be the same payer mix as if you chose the hospital. Most private for-profit midwifery practices, they can't financially stay afloat with the in-network contracts. They don't have the revenue of other departments and surgery and all these other things to offset. maternity care is not a moneymaker for hospitals. That's why over the last 5 years, we've been losing so many community-based hospitals having labor and delivery services because they can't financially keep it up with the in-network model and the volume that they're serving. So I always stress to people, just don't ever instantly think, well, they don't cover my insurance. It's like, okay, do you want an 8% C-section rate? Do you want a 33% C-section rate? Do you want one-on-one support, someone to come to your house the next 2 weeks after you have the baby? Hospital doesn't do that. As soon as you leave the hospital in 2 days, they will see you in 6 weeks. And that, we do terrible jobs postpartum, let alone the birth side. Like, we are so broken. The midwives got it figured out in the community-based setting. Like, my breastfeeding rates, I was competing with major organizations with my private practice on my outcomes. Like, we would have a 99% breastfeeding rate by 6 weeks postpartum. We would have, but not like minimal tears, like minimal bleeding, minimal complications, low C-section rates. But it's intimidating. I mean, the hospital system, it's a competition, and there's a lot of regulatory things in the backdrops. Like, when some states, midwives can be completely independent practicing, and some states, they have to have a supervising relationship with a physician. They they can't prescribe prescriptions on their own. So I always tell people, if you're thinking about becoming a nurse midwife or any APRN, learn about your state regulations and where you may be in the future, because you think, oh my goodness, I would love to be a home birth midwife. And then you figure out that nurse midwives can't have home birth practices in that state. Like, you just have to, it's not just the scope of your training, it's also the state regulations of where you're practicing. Unfortunately, we have 50 of them to worry about. So
yeah, that kind of, is there anything else that you feel like you personally as a midwife had to learn the hard way? Like
tons of things.
Things like that. I mean, I would be so devastated if I didn't, research that, if I had this expectation in my head that could be, I could be a home birth midwife, and then that not be the case for me in my state.
Yeah. Yeah, I mean, many midwives go through this. They have this, like, I grew up with Ina May. I grew up with the hippie, crunchy, normal, kumbaya midwives, and that's not our healthcare system. That's not like, there's outliers, there's little pockets, and I would love to see more of that happening, but that's not the norm. I mean, most nurse midwives are not starting their own private practices. They're working for a hospital system. They have a version of what they may or may not be a midwife like, and then they join a hospital organization that has a different philosophy, has a different relationship and support, that sometimes the midwives are treated more like physician's assistants and teachers to the residents, the next version. They're used for subset pieces of their skill set versus full scope midwifery. I was very blessed. I went to Fairbanks, Alaska as a new graduate my first year and a half. If you want to talk about the most autonomous place that midwives can practice, you are just, like, I came in, I was part of, like, we would be primary care providers. I would diagnose my patient with breast cancer, and I was the lead of the team for oncology and everything the family practice physicians would do. Yeah. And then I would move back home to the lower 48, and then I'd be like, I somehow didn't become incompetent, but it's the culture, it's the norm. And so there's pockets, there's places, the Washington, Oregon, Alaska have it really well. Colorado is doing great. I mean, I know the ins and outs of the midwifery and birth center regulations in the United States. So it's not just saying, well, I want to be a midwife. Talk to different people in your community. Learn about the history. It's not just you starting a private practice. If every hospital is very quote unquote hostile, they're hard to work with, like transfers, relationship building, you're still going to have worse outcomes because you can't do everything. So I think it's really important for midwives to just think or a nurse considering becoming a midwife, there's a lot of ways to practice as a midwife. You could be a clinic-based midwife, you could be in the hospital, you could be birth center, you could be home, you could be international. I mean, there's so many nurse midwives serving, there's the Physicians Without Borders, if I recall, Providers Without Borders. So it's just, the sky is the limit. And I think that's the whole point of your podcast, is like, nurses can be anything. They can run businesses, they can work for people, they can have side hustles. I do a lot with my business, not just helping private traditional practices getting going, but niche practices like midwifing the midwives is a big theme we talk about, because there's inventions, there's things that are missing to support midwifery and to support better healthcare that midwives are just creating. So you could be anything. You could absolutely be anything to better outcomes. It doesn't have to be just on the front line catching the babies.
Yeah. we're going to talk about CNMs most of this episode, but I know that there are different ways that you can be a midwife. There's different pathways. Do you feel like, and we were talking about how limiting, CNMs can be in their practice already, but talk about like the different types of ways that you can be a midwife, and, is one type of midwifery like restricted to, birth centers or home births versus like working in the hospital? Like, how does that work?
Yeah. I had a good friend. She calls it midwifery is like alphabet soup. I can think of at least 5 pathways to becoming a midwife. And this is what gets people really confused. And then you have to, there's 50 states and there's regulations for each state. Like some states have midwifery boards. Some states have midwifery boards for just the licensed midwives and the certified professional midwives. Then they have a nursing board for the nurse midwives. Like, it's very complicated. So I think it's really important for people. Like, there's a lot of nurses. You don't have to be a nurse midwife. You can actually choose to be a certified professional midwife after you're done with nursing school. Because there's a lot of people are like, I don't want to do the midwifery, more medical model of training. I want the alternatives. I want the homeopathies. Mm-hmm. I'm in a state, there's some states where certified professional midwives, community-based midwives have more autonomy than the nurse midwives do. In some states, the nurse midwives have more autonomy. So I wish I could tell you it's a flat thing. It's complex. So I'll give you an example. In Michigan, certified professional midwives, and about 4 years ago, got licensure. Before that, you were illegal. ALLEGAL. You weren't illegal and you weren't legal. You were in that gray zone because there was no regulations. Just like we don't have birth center regulations in 5 different states. So if you open a birth center, there's nobody on a law level saying you can do it or you can't do it. So they were in this gray zone for many, many years. And there's still lots of states out there like that where they're practicing and they could be questioned. Are you practicing medicine without a license? Because you have nothing to defend yourself to say, I can practice this here. You're in a void. So to the legal sense, it's good and bad to have an illegal state. But so the transition, nurses and nurse midwives in Michigan cannot own a business. Like the law, there's a Nurse Practice Act that's a paragraph, and it was from 1995. And then an attorney general position came out around 2008 saying they have to be nurses have to be supervised by a physician to practice. There's nothing about APRN. So I've been fighting for 10 years and like finding loopholes and legal strategies because I want, like, if we're safe practitioners and we have massive provider shortages, why is this happening?
Right.
And this is why it's really important to me of like lobbying in legislature and really advocating for what you want to do in your state, because there's a lot of states where nurses, not even just APRNs, can own their own businesses. They can support and create these wonderful structures, nursing homes, IV infusion sites. Like, there's so much. When we go into our bonus episode, I'll talk about the business side potentials for nurses.
Yes, absolutely. So do you think, how do you is there any efforts to kind of centralize a network of individually practicing people? Like, or is it just really blocked by like state to state limitations?
We can have unification in education and advocacy. There are some wonderful national organizations. American Association of Birth Centers is a great national resource for someone that wants to start a birth center. MANA, the Midwives of North America Association, is the Certified Professional Midwife Advocacy. So it's Canada, U.S., and Mexico, the North America. And then for nurse midwives, it's the American College of Nurse Midwives. They all have different slight philosophies of scope and practice and standards, but they're the national resources. But there is a massive void, and that's what I'm trying to fill with my private practice and what I'm creating for private practices and business and autonomy and advocacy for that grassroots level. It doesn't exist much. It doesn't, unfortunately. We need to get more, because what happens is CPMs are doing legislature, CNMs are doing legislature, and they're both trying to create the same thing in the end, but everybody's just trying to do their own thing. And we need to get more cohesiveness with the midwifery organizations and the community-based midwives.
Yeah. I remember in the podcast that I listened with you and Augustine, you were talking about how the most successful midwives practice together, or like they are connected with other, businesses.
Yeah.
And it makes so much sense based on what you're saying. It's like all the strikes are against you when you're trying to create your own practice.
Yeah. Well, and it's interesting because there's paradigm shifts. There's two key styles of midwifery in the community-based setting. There's the style of more of the older generation where solo midwifery means I am completely taking care of her. I rarely take a vacation. I rarely have a separation, because if she hired me, like, instead of thinking the midwifery model is what she hired, she wanted one-on-one support. Midwifery means to me that I am completely there and available for 5 weeks for her. And that's pretty exhausting and I did that for a long time. Like, that's a very unrealistic, long-term sustainable model. And you can only do so much. If you're self-employed, you only have so much time. And that was part of my burnout in 2017 with my private practice. I ran out of time. I ran out of an identity outside of being a midwife. We grew so big so fast that I'm working 120 hours a week doing birth after birth and missing births because you can't be in two places at once.
Yeah.
So Augustine and I are really trying to push with the younger, newer generation of team-based abundance, collaboration. They want the midwifery model. Let's get 2 to 4 midwives, 3 to 5 midwives together so you can go to your daughter's dance recital. You can go to your boy's baseball game. I can tell you story after story of the sacrifices my family and my personal life had because of midwifery. And I don't want... It's not sustainable. I mean, you have to have more of an identity than being a midwife. So I think that's part of setting good boundaries. Like, a lot of people choose not to be a midwife in the community-based side because of myths. They're like, oh my gosh, my midwife that took care of me, she already had 3 heart attacks. She's got diabetes. She's divorced. Her kids don't like her. Like, I don't want to be a midwife. Like, we have to know there's other ways to do it. And we have to know. So my goal is to break down myths with midwives and nurses and women in general. What is possible? What are you passionate about? What do you love? There is 1,000 ways to do it. And there's structures, there's business entities, there's ways to do it. I think that's why a lot of midwives, particularly nurse midwives, choose the hospital setting, because they're like, maybe I'm a little more medicalized than I want to be, but I'm on call every 3rd weekend. I'm in the office 2 days a week, and I've got 1 to 2 24-hour calls, and they're not dependent on me. And if all of a sudden I'm sick and I'm not running the business side and I'm not 20, so there's a lot of things that can make very strong structured practices, but we have to get past this scarcity versus abundance mindset. Like, too many midwives will say, I don't want to train anybody because now I'm training my competition that's going to open in 2 years. And I was like, there are so many ladies to serve. You have a huge waiting list. You can just send her your waiting list now. It's okay. I had a wonderful midwife, Madeline Murray. She does believe in midwifery. So if people want another wonderful resource to look into midwifery options, she's a certified professional midwife. She hit it home when she described people drive a large distance to go downtown restaurants because they have a lot of choices down a strip. They have culture, they have diversity. Your style of midwifery is not going to serve every single style of client. Like, if you have 3 to 5 midwifery practices with different styles in a community, we're going to make a bigger impact than just one that's kind of more underground and hidden. Like, we have to grow. We have to get past our own mental egos or mindsets that we have. There's so much abundance. There's so much opportunities with midwifery.
That makes so much sense because, the more that it grows, the more businesses you see, just then you, as a patient, as a client, you just kind of get more used to the idea of this is a option for me, So, I mean, it works out in the long run. I know you do some locum assignments, and for people that don't know, I didn't know the word locum before I talked to Leslie. So, it's travel assignments for advanced practitioners, right?
Yep. For providers, so physicians, dentists, APRNs, PAs. So nurses, it's typically called a nursing travel assignment, but for advanced practice providers, it's called locum assignments most of the time.
So what is that? Tell me what that's like. I mean, how are contracts normally? Because for travel nurses, they're normally 13 weeks. So talk a little bit about what locum travel nursing as a midwife is like.
Yeah. I'll go right to the backdrop of it's a very unique specialty of midwives. I mean, especially people know few about midwives, let alone there's about 5 different locum agencies across the country that support midwives.
Okay.
It goes versus like you can look and you'll find 2,000 traveling assignments for nurses. There's probably 30 to 40 on average across the country for midwives.
Okay.
But there's also a tinier pool. I am aware of a dozen midwives that practice and do locum assignments. So, I mean, it's all relatively speaking of like ratios.
Yeah.
I'm actually in the process with Empowering Midwifery Education, creating a locum midwifery training course because I get asked questions all the time because it's not, maybe they did labor and delivery traveling, but it's different as a provider. So I've been doing a locum assignment since 2016. I started a little bit when I had my private practice. The intention was to get privileges so I could help with transfers for epidurals, barriers. They had a need. Like, I'm a business owner. I'm an entrepreneur at heart. They had short-staffed with their doctors. They had one midwife close to retiring. They needed help at nighttime. So me and my partner for my private practice, we created a locum contract with this hospital where we covered the night shift and rotated between her and I so we could get some privileges. And so that was my first exposure to locum midwifery. It was a little over an hour from my house. It was a place I had worked as a nurse before, so I knew it. So it was like that perfect like branch of what is a locum. The big difference between a locum midwife and a permanent midwife is you're filling a need. You're there short time. It could be 13 weeks. It could be up to a year. Most of them are 3 to 6 months. You can easily extend. It just depends on the intention. If you're filling in for maternity leave, it's usually 3 months.
Yeah.
If they're short-staffed and they're having a hard time recruiting, there's massive nursing and provider crisis of staffing right now that they're just desperate for help. And so when you're a locum, you don't get 2-3 months of orientation. You jump in, you get 1 day, maybe 2, and you just have to be adaptable. You have to have strong skills. You're filling a need. You're there for a purpose. They're short-staffed. I've done Indian health reservations. I've done private practices. I would love to do more locums with birth center home birth practices. The challenge is they just don't have the finances to support what it costs to get a locum because they have to pay for their licensure, their malpractice, for them to come into town. There's some extra costs that the hospitals and the government can fund at this point.
Sure.
So I have since 2020, since COVID, I've really been full-time So I'll give you an example. The last year, I was at 2 IHS facilities. I spent 3 months at one, took a 2-month break. Then I did 5 months. I did 3 months, and then I chose to extend. We homeschool our kids. So my consulting business, I can do from anywhere. Like, I wanted to be able to travel the country. How can I make midwifery and nursing? And I want to catch babies. I want to support women, but I don't like the politics of the healthcare system. Like, I'm not a good employee. Like, I've tried that after my private practice closed. I tried to become a W-2 employee, and I would see challenges and problems and issues that there's a very different mindset between a business owner and corporate. Like, you get your paycheck, you just do your job. I was like, this is broken. This project like this, like, let's improve this system. And they don't
so much
hire
red
you
tape.
for that. Yeah. And I'm used to that spoiling when you have your private practice. There's an updated standard. There's an issue problem. You can fix it in 2 weeks. If you go through the big tapes of the healthcare system, hospitals, it takes 2 years. So those are the perks of running your own private practice. So locum was good for me because I made good money. I fill in gaps. I get to write off everything I'm doing because it's a business. It's 1099. If you're a nursing travel assignment, most of the time they still count you as W-2. They still count you as overtime. They don't let you write things off. They give you a stipend for your housing and food. When you're a locum and 1099, an independent contractor, you get to write everything off for your travel in your business. And so it's a mini business within them. It's a different respectful relationship. So we went camping last summer. We took our kids cross country, and on my days off, Yellowstone, Grand Canyon, saw the board. I mean, like, it's the best of both worlds. I'd work for 3-4 days. I did the night shift covering for this Indian reservation and really enjoyed it. It was a great experience. And then we got to see the country, and so it's the best of both worlds. So locum assignments are awesome because I don't have to attend meetings for staffing and drama and compliance. And I've got my certifications. I've got my skills. I just show them on a piece of paper. IHS facilities, they need help in 2-3 weeks. I don't have to go through red tapes of a state licensure. I can get in really quickly. And especially if I have privileges, they can call me on Friday and say, hey, can you fly out on Monday and come help us for a few days? So I currently have privileges at like 10 different hospitals.
That's
the country.
amazing.
So I'm versatile. I think that's part of learning your personality as a nurse. Like if
Yeah.
you love like, oh my gosh, thinking about business and money and hiring and training makes me want to vomit. I love just going to my job and serving my patients in front of me really well. That's okay. That's
Yes.
awesome. So there's just, I think the whole point of nursing Uncharted and just in general, the sky's the limit. You can be anything if you just talk to the right people and learn. There's so much out there if we just
Yeah.
open our eyes and think outside of our comfort level.
Yeah, absolutely. I mean, yeah, you hit the nail on the head. I wanted to ask you about traveling with kids because it's something that as travel nurses, it's a barrier of what people think that they are able to do or not do because they have kids. And I
Yep.
haven't actually had the chance to have somebody on who's a travel nurse with children. So how old are
Yeah.
your kids and what does that look like as a
Yeah.
traveling nurse?
So I have three boys. So they're 12, 10, and 4. I
Oh,
joke my private practice was in that gap. So, I mean, that's the identity where you can't, like, I could tell you stories of just crying where I take out my IUD and then all of a sudden I'm solo practitioner and bawling because I'm like, I can't be a mom. But yeah,
yeah.
so it was really important. After my private practice closed, I said, any business venture, anything I do, it's going to be side by side with my family. It's going
Yeah.
to be my kids and my husband. I've been with my husband's high school. Like, it's one of those things. I knew the divorce rate for midwives was high. So I literally, when we started dating, I was like, I'm going to be a home birth midwife. Do you want to be a stay-at-home dad? Like that kind of attitude. Because I knew
Set
like
that expectation.
well, yeah. So my husband, since my oldest has been born, he's the rock. He would do the accounting, the backdrop stuff. Like he's still with our business and the backdrops. Like he is the most amazing guy. Like you have to find that right partner in life that is like, this is what I want to do. Eventually, I want to do international birth center consulting. I want to travel when my boys get a little older, taking them one at a time with me. My husband has no desire to do international traveling, but my kids do.
Yeah.
So back to it. There's lots of nurses that bring their kids, they homeschool, they travel the country. I would say half of the nurses I meet actually have stay-at-home dad, husbands, partners, and they travel the country with their kids.
That's amazing.
Yeah, so I think part of it is getting past that mindset of what is a good family and what is a good way to raise your kids. I think a lot of it is our stigma. Like I get crap from my family all the time, like about I homeschool, I home birth, I go across. I'm not the typical family, but my kids are doing so well. I think they're doing above and beyond the average. They can relate. They're adaptable. Military families do it all the time. Like we don't give a stigma of, oh, you're
So
a bad
true.
dad or a bad mom because all of a sudden the government told you had to go over here 3 months later. Like my brother-in-law and sister-in-law are in the military and they've been in it the last 18 years. Their kids have been in multiple different countries. They're just told in 3 months, you're moving here, and they sell their house and they do it. They're adaptable. They're resilient. So we have to get past this mindset of when is it okay? It's okay for the military and government to do that to families, but we can't do it on our own.
Yeah.
There's a lot of great homeschooling programs out there with the internet. And I mean, we just have to make sure when we're camping, we have good internet access for my kids to do school. So it's a learning curve because some people are conditioned. I can't teach my kids. I can't homeschool. And so you want to like test it. You want to practice. It's not nearly as encompassing as people think. Like it's 2.5 hours a day and 90% of it is done online. And then you ask, especially the age my kids are at with the 10 and 12-year-old. But it's getting, you got to have a family unit that's wanting to travel and wanting to be adaptable. We just winterize our house and then we come back. And so we have a grounded place to go to. Sometimes they go with me. Sometimes they don't. Like I can make my schedule and my hours where I do a long stretch for 6 days and get eight days off. So I'd fly back and forth often. So when I was in Arizona, the first 3 months I was solo and then I would fly back. Because a lot of times I want to test the water, the area. Is it safe? Is there a lot of tourism? Is this going to be a place the kids are going to like?
Yeah.
So the first 3 months I was solo and then we extended and bought a camper, went across country and we would just stay in the camper. And then once in a while we'd stay in a hotel, find some fun places to go. But I think it's just adapting and being open to try new things and to think about, I mean, people do it all the time. And I met amazing nurses that do it as well.
Yeah, I think that just we're just our biggest boundaries. We're our
100%.
biggest limitations as far as what we think
what
that
we can
we're
do
able
and
to
what
do.
is possible. Mm-hmm.
Yeah, right. And so it always just helps to listen to somebody that has done it and be like, this really is not
Oh my gosh.
as hard as we make it out to be.
Oh my gosh, like with COVID and the kids and like the mask and the socialization, my kids got to skip all that. Like I think part of this stigma of sometimes we need to fit in. Like I've never been a person that's fit in. I've never been the norm. I've always questioned things 1,000 different directions, and sometimes it's good and sometimes it's not. But I think when we start learning, what do I want out of life? What makes me happy? What do I want to do? Because I promise you, when you're on your gravestone and you're on your deathbed, you're not going to say, man, I wish I'd have worked more hours. You're going to talk about all the life experiences. And I wish I would have spent more time with my kids. I wish I would have traveled here. I wish I would have got these things off my bucket list. Why do we have to wait till retirement to make those things happen? Why can't we make those things happen now?
Yeah. I feel like you're going to breed a bunch of nurse midwives from this conversation.
Love it. Well, and I don't care. Like, they can reach out to me. I will put on the plug-in at the end of both conversations. I do discovery calls for 15, 30 minutes, no strings attached. I have people, I don't care what your profession is. You're a woman that wants to start a business. You're a nurse. You want to chat. You want to brainstorm. You want some guidance. Like, I love, because it's a ripple amount of change that's going to happen. And I'm a big visionary. So yeah, please, I don't mind if people reach out to me and we brainstorm and talk about their unique goals. So
what do you think, just kind of bouncing off at this, I think that we're going to wrap this up, but I just wanted to ask, as far as what you think what do you hope for the future of nurse midwifery?
I hope for the expansion and access. I mean, I want us to have better outcomes. I want our next generation. My midwife retired. I had to beg her with my 4-year-old to come out of retirement because there were no home birth midwives. And I was deathly afraid of being unassisted. Like, I know what can happen. I can't do a postpartum hemorrhage and a prolapse cord and a shoulder dystocia on myself. I just can't. Like, it's rare, but we want lifeguards at the pool. Like, that's what I stress midwives are. Like, we're here just in case you need us. So, like, I'm very respectful of that relationship. Like, I want my sons to have better birth options. I'm not just nurse midwives. I want more nurses and autonomous care providers out there, because there's massive voids with physicians, and we need more APRNs. We need more nurses starting businesses and being autonomous and doing stuff that makes them happy. I mean, with COVID right now, the burnout rate for healthcare professions and choosing other careers is astronomical. Our healthcare system is on the brink of collapsing. It really, really is. Yeah. And I want to, if you figure out, I think the whole point of this inspiration is, if you're a type of nurse and you figure out, oh my gosh, this doesn't work for me, I don't like the hours, I don't like who I'm taking care of, I don't want you to say, I am a bad nurse and I just can't be a nurse. I need to find a different profession. I want you to shift your mind. I am a damn good nurse. I just am not good for this. My life has changed, my philosophies, my beliefs, whatever the situation. I need to pivot how I'm going to take care of people and reevaluate what makes me happy. Because we can do anything. We have them out of all occupations. Honestly, nurses can do absolutely anything with their 1 degree. Yes. So I think the whole point I have is I want nurses to not feel discouraged and feel like, man, the system is too big and too broken. Type of nurse I want to be, the type of midwife I want to be, I can't be it. There's people out there that can show you and direct you how you can be any type you want. Maybe you have to move. Maybe you have to reinvent a different angle and get inspiration, get legislature changes, get a group of people together to make this new organization, make this new vision you would love to see happen.
Yeah, but it can happen. It can 100%. Happen to you.
Yes.
Absolutely. I loved this conversation. I loved talking to you and listening to you. This was such a wealth of knowledge. And I cannot wait to do this bonus episode. So if you are interested in learning about how to build a business as a nurse and in nurse midwifery, we're going to have a short bonus episode with Leslie all about how you can build your own business. And so that will be after this episode. But Leslie, thank you so much for coming on for this episode. This was wonderful.
Yeah, I'll send you all over my resources. I run midwifery business consultation and empowering midwifery education. I have a few other side small businesses, but I think those are the main ones they'd love to learn about. But yeah, we'll give a link for my discovery calendar. I love to talk to new aspiring. It's the next generation. We need to get a different paradigm shift with our healthcare professionals. So I would love to chat with them.
Yes, wonderful. All right, Leslie. Well, I will talk to you soon.
Okay, sounds great. Thank you.
That brings us to the end of the show. Thanks for tuning in to Nursing Uncharted. To learn more about today's episode, make sure to explore the show notes at americanmobile.com/nursinguncharted. And don't forget to subscribe so you never miss a guest. If you're a nurse interested in traveling, visit americanmobile.com to explore the largest database of travel nursing jobs in the industry and the amazing benefits that American Mobile has to offer. Also, a special thanks to producer Jonathan Carey, assistant producers Katie Schraubman and Sam McKay, and Aidan Dykes for the music and editing. Until next time, take care of yourself.